Good afternoon, everybody, and thank you very much for the opportunity to join you and speak at this wonderful meeting. Great to see so many of you here. So I've been given the title of Functional versus Surgery, so I hope I'll give you some useful data. These are my disclosures. My institution demands that I show them to you whenever I speak. I don't think they're particularly relevant today. I think the reality is there's a huge difference when we look at this problem between elite sport and what we do with the rest of the population. And the registries and follow-up give us some very sobering data for surgery. So there's no doubt here that the takeaway is there's a clear role for non-operative management, or what you call functional management, and a clear role for surgery. And it's up to us to unpick it. And that's not straightforward because it is a multifactorial process that's dependent on the gravity of the injury, the quality and the technique of both surgical and functional management, the resources available, the patient's profile, and quite a lot of unknown variables that we probably haven't thought through yet that Bertrand's going to study for his next PhD. So we need to stratify our patients. There's a degree of injury, both clinically in terms of grade of laxity and on imaging. There's age and expectations and activity profiles. There's all the issues beyond the knee that we as knee surgeons recognize that will factor in what happens with an ACL injury. And of course, there's timing, and then there's the whole psychology and ability to adhere. So the answer is there isn't one biomarker at this stage. In the AI world, we may get there soon, but right now, predicting the winners and the losers is very much a surgical skill. And remember, there are other factors at play, such as the menisci, that will alter our decision-making. So before I started thinking about this, before all the studies I'm going to talk about came about, I would break it down into the patient's activity profile, their injury complex, whether there is a risk in delaying and seeing what happened in rehab, what their future was likely to look like, and what they wanted and needed. And in reality, more often than not, we can reach a reasonably straightforward early decision for that patient. But now we've got a lot of good level 1 data to work through, and that will help guide your practice. It certainly guides my practice. I think the first of those studies was Stefan Lomander's group doing the Canon trials. This will all be familiar to all of you, so I'll skip through it quickly. 121 patients, KOOS as the primary outcome measure, ACL versus non-ACL. These clearly aren't elite athletes, and it was criticized a great deal at the time, but actually a really important study. And they followed on, and 5 years in reality, those showed that you could easily send patients to a rehab pathway without incurring significant risk. Of course, out of those rehab pathway patients, almost half went on to have an ACL reconstruction, but there was not a huge downside in terms of secondary damage for those patients. So a clear message that actually we could try non-operative management. One issue with this study was that the laxity data wasn't great, and some surgeons were not convinced. It's always good to have corroboration for any study. Concordance is really important. So the COMPARE study comes along, a really important study, slightly bigger RCT, again, structured rehab, acute injuries versus reconstruction early, within 3.5 months, and then looking at what happened beyond that. In this case, there seemed to be a statistically significant difference in favor of surgery, although whether that difference was clinically important is something we can debate. But the scores were better. Interestingly, they then went on to look at this in more detail, and the fun in RCTs often is the exploratory and the secondary data when you come on. And when you look at those rehab patients who then went on to have surgery, well, there's no surprise there. They were younger, they had a higher activity profile, and they did more sports preoperatively. They were those patients you would intuitively have thought might veer towards ACL reconstruction. We've also, I think, debunked one of the myths. We've all seen patients whose so-called ACL injury has looked like it's healed on MRI scan and have a stable knee. And it's helpful to have a paper from Lomander's group that actually supports that, in that there is now good evidence from a randomized study that some of these do heal. So the reality is there's good evidence for non-operative management, but you also need to consider what that non-operative management looks like. how soon it starts, how unstable they are at the time, and whether, frankly, you use any adjuncts. So those are all variables that need to be built in and available from that point of view. And in reality, bracing, and I was expecting you to hear more about this in the previous presentation, bracing now seems to have a role from that point of view. You'll be aware of Tom Cross's work trying a bracing protocol in order to manage ACL injuries. This is interesting to the outsider because I don't think bracing is completely benign. This seems to work for some patients, but having patients braced and offloading for over 10 weeks is actually quite a demanding intervention. And it is not one without risk, as you'll see here, in terms of loss of motion, in terms of thromboembolic complications and re-injury. So what non-operative measures you put in, you've got to understand the costs for as well. In the UK, we have a funny healthcare system where we have a private system and we have a national health service system where care is much slower. So we thought, led by David Baird, but many of us involved, to study this in a UK setting where we're dealing with non-acute cases, to look at those subsets that weren't looked at in Canon or Compare. Pretty similar, bigger number, but essentially randomized to ACL reconstruction or optimal NHS non-operative management with COOS as the primary outcome. Multiple sites across the UK. I stress this to you because not everybody's a Bertrand or an Elvire doing 5 million ACL reconstructions a year. Some of these guys are lower volume ACL surgeons. So big study group. That's the consort for you. The paper's published in The Lancet if you want to have a look at it. And they're pretty well-balanced groups, more males than females, typically in these studies. And when you look at it over time, this is the headline, a bit like the Compare study. We've seen better outcomes in the surgical group versus the rehab group. So again, for non-acute tears, there seems to be a role for surgery. Interestingly, about 80% of the surgical patients would have the same treatment again. 60% of the rehab patients would also have the same treatment again. So again, a little bit in favor of surgery, but essentially all the secondary outcomes favored surgical intervention in this cohort. I said to you, generalizability may be difficult. A very small proportion of these patients actually got back to sport. That may be to do with the fact they're in the public health sector. So how do we conclude from all of this? I think evidence-based ACL management means that if you have an acute ACL rupture, if you're a lower grade of laxity, you have an interstitial tear, you're older, your rehab program can start early, and you're not particularly active, Canon tells us a non-operative program will work very well. If you're younger, you have a higher level pivoting sports participation, Compare tells us that it's okay to do early surgery. And I think if you have a non-acute ACL tear, SNAP tells us that ACL management is okay, but it's also okay not to do surgery. So to finish off, in the UK, we consider a shared decision-making model as really important. And I think in reality, if it's acute, you can rehab first, but it's not wrong to do an ACL. And if it's non-acute, they probably are presenting because they're unstable. They need an ACL, but it's not wrong to do rehab. Thank you very much.